I'm Bridget Meehan, and it's my pleasure to be chairing this afternoon's session. And our first speaker is Mikaela Shannon, and her topic is going to be what works in quality assurance for Aotearoa's aged care medication management, evidence and outcome. That's very interesting. And Shannon is the Enliven's Clinical Director at Presbyterian Support Central since 2023. She brings over a decade of experience in patient safety and quality improvement across healthcare settings. Before joining Enliven, Mikaela spent 10 years in leadership roles at Aotearoa, where she specialised in safety, quality improvement, acute care and older person services. Her extensive work at Aotearoa included implementing care bundles such as the National Signalling System for Falls Prevention and leading projects in delirium management and the Care with Dignity initiative. So she's the clinical director and she's ready to talk to you today about quality assurance. So over to you, Mikaela.
So I'm a doctoral candidate for Victoria at the moment. So I'm halfway through my PhD. I decided after COVID that I would do something for me, whether that's a PhD, I'm not quite sure. But and my passion is quality assurance. So my supervisors are Kim and Brian from Victoria. So my passion really, I've started sort of, if you like, networking and looking at actually what is there in quality assurance. If you think of quality assurance, everything's tagged on to the end of a policy or end of an audit, or a lot of it isn't interweaved into everything that we do, but we are judged by it by certification, compliance, data that we collect. So when we look at interRAI assessments and things like that, we're collecting data against stuff that actually our quality assurance isn't interweaved through that. Through my research at the moment, I looked predominantly at quality assurance in healthcare, then looked at we were trying to apply a Western model within New Zealand, which doesn't quite fit when you look at Ngāti standards, our interRAI assessments and how that we're trying to integrate Aotearoa's kind of culture within them assessments. So I wanted really to look at something that was really resident-centred and could start to sort of bring out things that are practical. Being mindful that most of our workforce are unregulated staff within aged care. So how does that apply? And all of us sat in this room, you'll probably think about what policies and procedures you've got. When I started to drill down on medication management quality assurance, our policy was 69 pages long within the service that I work for. How compliant is that to be able to apply a good standard of practice alongside our assessments and things like that? So really done some sort of deep dive into the quality assurance program. We've got some real sort of, I did a timeline from the year 2000 to current time now, because we've got two significant papers within health. One was the quality chasm and the other one was report to error. So we've had some really major studies on quality assurance, that how we can link that into our practice, but we actually keep on reinventing the wheel instead of actually saying what we need to do to remove some of that red tape, the 69 pages long policy. So my research aim was very much to look and, if you like, explore, explain and evaluate. So looking at the process, using a realistic evaluation of what works for whom and why. We want it to work for the residents just as much as we want it to work for our staff. So most residents actually come into aged care, can self-administer, but we put them through like 10,000 hoops to be able to self-administer. And if you think that, give you one scenario that I was working on trying to get to this point, was talking to some of families and some of our staff. If you had to do a medication round and only had to do 5 medication rounds instead of 25, how safe would that be? So therefore, you've got your quality assurance interlinked, really. That helped me come up with kind of my research question and that aim to think. Within New Zealand, we've got these sort of leading ways of literature. We've got to publicise what we do. There isn't enough out there on medication management within New Zealand, as we were nicely highlighted this morning, we don't publish everything that we do, even though there's been some studies that are done, they're just not published. So therefore, we can't use them within that academic review. These only have about sort of 50% of quality assurance measures within them. And that's what I meant right at the beginning. They're often weaved at the end of something to be compliant with something rather than weaved all the way through. So I'm hoping my research will actually give people some guidance on how to weave it from the beginning to the end, instead of just thinking, oh, yep, tick, I've done the quality review at the end. When we look at sort of how we make it not a westernized model, we really want to do that sort of different framework. So within this, there's a lot of the literature that we looked at. There's about 7 grey literature reviews that have been done within New Zealand within the last 10 years that actually really give us some good framework on how to put it into an Aotearoa model, rather than actually using a westernized model to do our policies and research. And if anybody's looked at the Ministry of Health, our actual policy for medication management, there's 3 of them that guide practice across different aged care, home care, and they're over probably now 12 years old, out of date. And they are reviewing them this year, which is a good thing. So they're starting to integrate the next sort of stages. So I'm hoping, I know my research probably won't inform it, but I am on the steering committee, which is good. So it's having a voice and making sure that the right dots all connect up. So the research gaps and why it's important is that we actually need something that is safe, but actually informs practice and policy, not just a tick. So non-compliant documents and more legislation doesn't help us collect good data that we need. Because at the moment, the data that we do collect is obviously incident data. We do have some interRAI data that it's benchmarked and it's not directed to the right people. So our unregulated staff don't always hear about what happens to interRAI data, which actually, if they did, would that change practice? So I'm hoping that through looking at sort of some of this significant sort of literature, that I'm going to establish some focus groups that will work in different levels. So the first focus group very much, I think it'll be this slide. Yes, sorry, it's very busy. But the first focus group will be health experts, and they'll look at actually what informs policy, whereas the next level will be our unregulated staff and actually doing some demonstration of tasks to see actually what works and why. So actually try and get some qualitative data out of it. And I'm using the interRAI data in a different way. So I'm going to be using it through my journals and collecting people's thoughts, so that actually my journal work will be able to provide some data and figures to match actually what people are saying in practice. So it took a little bit of while to get through ethics, because they were like, it's got to be either mixed or one way or the other. But now that I've got through that, we're allowed to start, which was quite good. So it's really analysing some of the tools that we've got and mapping them theories to be able to test them in practice to see if they work or not. So this bit here is mapping theories. If anyone's used realist evaluation, it's very much about looking at sort of different sort of ways in doing things and how that relates and how it works for people. So for instance, I could stand here, write a policy and say, actually evidence-based says A, B, and C, but when they're actually doing it in reality, they might only have 2 staff, not 7, and how does that apply? So you're actually looking at sort of different sort of mechanisms. So I won't go to my unregulated staff and say, right now we're going to do some mapping of realist evaluation. You'd actually go, how does this work? You know, ask the questions, get them to have that discussion. Also have the ability to do smaller focus groups as well, which has been approved. So when I'm actually looking at the journal data that I'm going to think, a lot of it will be done because I work within some of the facilities that I'll be collecting the data from. I'll be very much on the sideline, kind of looking and seeing how people interact, what data they're using, what evidence they're using, trying to leverage some of the stakeholder data on what is evidence-based and whether that's being integrated into that practice and how it's being used. So really sort of things that came out from the literature is like that standard compliance and how it's applied. But really, we know that in practice, there's always that variation. So how do we get that variation within policy and using the data and benchmarking in an efficient way? So already the gaps, as my intro said, I worked at Aotearoa. Our data is already kind of public within the hospital. When I came into aged care, a lot of it's public, but in pockets, if that makes sense. So it's not public to public, but it's public in different sort of platforms and if you like that sort of hierarchy. So I can see it and managers can see it, but actually people on the floor, they can see their own data, but it doesn't mean anything without some contents behind it. So I'm hoping that the focus groups will actually develop some of that benchmarking to make it real time, have sort of real-time dashboards that are linked to our interRAI data to stop people from doing duplication, because I've seen that already an awful lot in aged care. There's an awful lot of duplication and people making pretty kind of graphs and everything else when actually the data's already there. We just need to use it, discuss it, and then make outcomes from it. So just being smarter with our time from that. So just to recap, the next steps are really, I've defined the stakeholders. So I've got people like Joe and Nairi, who you've heard talk today, who are part of my stakeholder group. I've actually got nearly 26 of them now, so I'm not quite sure on numbers, but we'll get there. Then into the phase of the force focus groups and then utilising my journals and things for that data collection. I would hope to feedback. I heard someone else feedback the next stages of the project. So happy to sort of continue the journey. Wanted to open up just for some questions, thoughts, because that's part of my journaling to see where to from here. Thank you very much.
Thank you, Mikaela. Do we have questions for Mikaela? Hello?
I was just wondering whether your research will look into any comparison between the electronic medication management systems and non, and I'm particularly interested in the impact of that on discharge.
Yeah, it will, and I suppose that's why I wanted the expert focus group, because I'm hoping that all of them things will come up. So they'll have a few kind of platforms of prompts, if you like, to say this is about, you know, our data collection, this is about policy, this is how things happen. I'm even hoping that you know, the delays on discharge from hospital, like, you know, if actually somebody entered it from hospital onto Medimap, we would be able to take someone on a Sunday, you know. So I'm hoping some of that stuff comes out of the data, or even the discussion with my journals, so that I can use the journals to publish some of that information as well. Yeah.
Are you using errors?
Yes. Yeah.
That's.
Oh, sorry. Yeah, I was just asked if I'm using errors within the data. So some of it will be interRAI and some of it will be, we've got a national benchmarking platform as well. So things like the Commission, they've got data that I can use. So as long as I needed them to approve my journal collection as a data set so that I could start to use all of that rather than having a load of quantified data, that I wanted to make it real so that someone can pick it up and go, okay, this works. Yeah.
So I have a question. Do you belong, does your organisation belong to the Age Residential Care Quality Indicator Benchmarking Group?
Yes.
Oh, you do?
Yeah.
Great.
Yeah.
That was
Yeah.
good.
And some of them are stakeholders as well. So it's yeah, a lot of it was just trying to be able to, you know, get them as expert stakeholders within my research, which that's just been approved by ethics. So
Lovely.
I'm allowed to say that now. So that's good.
Good.
Yeah.
Now you're free to ask whatever you like. Any questions for Mikaela?
I'll come back and share.
Yes, that would be great.
Yeah, that would be really good.
I do. I love those follow-ups when
Yeah.
you go away and do all the work and we just come back and hear another time. Yeah.
Yeah.
Oh, well, then I will call this to a close then. Thank you very much, Mikaela. And